Thank you very much, David. And I'd like to thank Feza and Phil and Amy for including me in this. And I'd like to give a personal thanks to any veterans that are here today. Just so I know who I'm dealing with, can I have a show of people in the audience that are surgeons? And then, thank you. And then gastroenterologists? Okay. So just where we'll go over the next 20 minutes, we'll talk about some of the operative indications for patients with large bowel Crohn's disease and some of the basic rules of engagement, if you will, what options we have and kind of the indications and concerns associated with each of those options, what outcomes you can counsel your patients about, and then we'll wrap things up. So we're all familiar with what the operative indications are, regardless of what the disease distribution might be, but failed medical therapy continues to be the #1 reason that we operate on people with Crohn's disease, including the large bowel Crohn's disease. And failed medical therapy can take a lot of different views if you talk about these younger patients that tend to be rather non-compliant with their medication, side effects associated with the medication, or more commonly, the medication just fails to get control or maintain control of the inflammation. There are acute complications and chronic complications. The acute complications we see are very similar to what we see in large bowel ulcerative colitis, where you see hemorrhage and perforation, oftentimes complicating severe colitis with or without megacolon. The chronic complications, the extraintestinal manifestations, is an unusual reason to operate, but could be a reason in our children. We see growth retardation, sometimes an indication for operation, whether it be from the disease itself or the medications used to manage the disease. More and more, we're seeing neoplastic transformation of this inflamed colon as our medical therapy gets better, and we're seeing people hold on to their colons for a longer period of time. And then lastly, obstruction with strictures that are refractory to other means of therapy. So regardless of why it is that we're operating for Crohn's disease, we need to remember that it's an incurable disease, at least in this day and age. Who knows what the future holds. But the intestinal complications are the most common reason that we operate. And there are a lot of different decisions that go into, or a lot of different variables that go into our decision making. You know, I think that most of us surgeons in the audience, our practice is beyond that of inflammatory bowel disease. And, you know, if we're operating for colon cancer, rectal cancer, we can pretty much tell you what we're going to do from start to finish without ever opening up the belly or looking inside. Whereas in Crohn's disease, I think you really need to be prepared to find or to respond to what it is that you find, and that the endoscopy and imaging studies that we have available to us are a rationale or a reason to operate. But if you were to base your surgery wholly on what those things predicted you'd find, you'll be likely doing the wrong operation in a significant number of patients. So because we can't cure the disease, if something doesn't look like it's bothersome, you leave it alone. And you can have non-disease bowel that's secondarily involved by the primary disease. Resection margins should be largely conservative, and controlling the mesentery can sometimes be difficult. And where we see it most is in the transverse mesocolon, it seems, where you get this really thickened mesentery that becomes very adherent to the retroperitoneum and can make a division in that area quite challenging. So the options, well, these are done in one or more stages typically, and I think that the gold standard that everything gets compared to is likely the proctocolectomy with endoleostomy. But we have segmental resection, whether it's the midgut or hindgut. You have a total colectomy, where you're doing an anastomosis between the terminal ileum and rectum. Total proctocolectomy with the pouch anal anastomosis that we've heard so much about. And then a little variant on that is where you're taking out all of the colon and the upper half of the rectum and putting a small pouch on top of the mid-rectum. But as we know, most people with large bowel Crohn's disease, their disease isn't limited just to the large bowel. That's a very small population of what it is that we deal with. But instead, you'll see terminal ileal involvement, more proximal small bowel involvement, and the most common thing that we see, obviously, is disease of the anus or perineal area. So the total proctocolectomy with endoleostomy, as I said, is kind of this gold standard that everything gets compared to. And historically, we always did this in an endoanal kind of fashion. But we know that as far as a one-stage procedure, we wouldn't be doing it for someone that presents with significant hemorrhage unless the rectum appears to be the source, just because it's too much of an operation in that setting. The same with perforation or severe colitis. And then lastly, if you have a patient with a pretty significant comorbidity, you probably are going to do whatever operation you can do to control their symptoms and get out of the operating room and get them off the table. The concerns is really how do you do the perineal part of this, and there's debate as to whether or not you do an intersphincteric dissection or an extrasphincteric dissection. Historically, we always did the intersphincteric, but in people that had pretty robust anal-perineal disease with multiple fistulas, when we were in Cleveland, we showed that doing that extrasphincteric dissection worked just as well for controlling that local sepsis without any downside. The downside that we're always worried about is this unhealed perineal wound, and even worse if there's a very long presacral sinus. And about the only thing that tends to mitigate against that is not so much surgical technique, but if you're able to control any kind of sepsis in that local environment before embarking on the proctectomy, and so which would favor a stage procedure in some of these individuals. Years ago, the group from Sinai Hospital talked about just dividing the bowel much as you would in doing a double stapled pouch anal anastomosis, and in doing that avoiding a perineal wound. And to their credit, they came back several years later to that initial paper by Mark Shearer and said, look, we've encountered quite a few of these individuals that developed malignant transformation in that area. And so they say that if you're going to do that, it's a staged procedure where you go back in a later time and do a proctectomy. So segmental resection, whether it's midgut or hindgut. Here again, if you have two or more involved segments, you're better off just doing a colectomy or proctocolectomy. If the rectum is no good, then it doesn't do any good to leave it in situ. Same with significant anal perineal disease. If that's why they're undergoing an operation, and if that's a large part of what their symptom complaints focus on, then that all needs to come out. If their sphincters are no good, again, that's fine. And we know that the neoplasia tends to be multicentric, and so that you need to address all the inflamed areas, whether currently or in the past. And so for neoplasia, usually you're going to take out a larger section than just a segmental resection. And again, oftentimes you're going to stage this procedure depending on other things that are going on with the patient. The colectomy with ileoproctostomy or ileorectal anastomosis. And here, this is usually done just distal to the confluence of the tinea. You don't want to do it if there's extensive small bowel disease because of this, or history of extensive small bowel disease, just because of the risk of recurrence and what that's going to mean. Penetrating small bowel disease, again, has a high recurrence rate, and so we tend to favor avoiding an anastomosis in that setting. If the patient has inflamed rectum or non-functional rectum, then preserving it really doesn't do any good. And the same with if they have poor sphincter function, because probably 40% of these individuals are going to have loose stools, and their continence is going to be quite compromised. And again, obviously you don't want to leave behind neoplasia, and you want to do a safe operation. So the concerns that we counsel the patient about, again, consider staging the procedure, but what's their function going to be like? And they're always at risk for recurrent disease, both proximal and distal to the anastomosis, as well as neoplastic transformation or degradation in that retained inflamed rectum, if it has had any kind of inflammation. Pouch anal anastomosis, if I were up here 15 years ago and talking about this, you would have said there's no such thing. This is you absolutely never do. But we do know that, that in selected individuals it can be done. If they have any type of small bowel disease or disease of the anus perineum, then they're not a candidate for this. So they're highly selected. If they have poor sphincter function, any kind of neoplastic problems in the rectum, or significant comorbidity, it's not an operation that we would offer them. But again, this is typically a staged procedure. You talk to them about what function they can expect, and we'll review that. They're at risk, obviously, for pouchitis or even Crohn's disease of the ileopouch or more proximal bowel being this recurrent disease. And then as Bob Petras, who is a pathologist at the Cleveland Clinic for a number of years, said there's nothing like a pouch to bring out the Crohn's in somebody. So you really need to be careful about that, but we'll see. And then this last operation is something that is done very infrequently, but there is a small cohort of individuals that may be candidates. And this is where you take the rectum down to about the peritoneal reflection and put a 10 centimeter pouch on top of that such that it doesn't rise out of the pelvis and they have emptying problems. And in doing this, about half the time we'll use proximal fecal diversion upstream of this pouch rectal anastomosis. And the contraindications are very similar to what you saw with the pouch anal anastomosis, with the exception of you can tolerate a little bit of anal-perineal disease in these individuals. They are sometimes individuals that have had some terminal ileal disease, but not extensive lengths of it. And so it's an operation that we would offer in that setting. Again, it's the same caveats that you would caution the pouch anal patients about in going forward. So how do these people do? Well, we know with the total proctocolectomy in a recent meta-analysis, as well as a review that came out of the Cleveland Clinic that Lucas Stocky was kind of driving. The overall recurrence rate is about 25% for proctocolectomy, and usually when they get recurrence, it's within 25 centimeters of the ileostomy itself. And this surgical recurrence rate, you can see, is greater than 10 to 15 years out. From the Cleveland Clinic, where they looked at 234 patients and using the Cleveland Clinic global or quality of life scale, they found a quality of life around 0.6, which is surprisingly low, and it's a scale with 1 being the highest. Other studies from the same institution have shown that they typically get a little bit better quality of life than what they found in this particular study or cohort they were using for comparison. So moving on from the total proctocolectomy and ileostomy to just a segmental resection where you're taking out just the midgut or hindgut colon and doing an anastomosis. Again, with that same meta-analysis that was just recently published, what we saw was that there are 10 studies where they looked at segmental resection. The overall, whether it be symptomatic, endoscopic, or surgical recurrence rate was around 56% with a 40% recurrence rate, and that was almost 10 years out. And you saw that the need for, over that period of time in those studies, the need for permanent fecal diversion was around 15%. For taking out the whole colon and doing a ileorectal anastomosis, what they found at the Cleveland Clinic in some 75 patients, about 20% of the patients had some form of anal-perineal disease, about a third had small bowel disease, median follow-up of 3 years, and their surgical recurrence rate in that time was 1 in 5 with a indefinite fecal diversion rate of 23%. And about 17% of additional patients went on to permanent fecal diversion, and the quality of life was very comparable to what they saw with their proctocolectomies. As far as the proctocolectomy with pouch anal anastomosis, the way that this kind of evolved is that there was a group out of France that reported their experience with this. There was some argument as to whether or not they were actually talking about indeterminate colitis as opposed to Crohn's disease, but it gave pause to a lot of folks to kind of question whether or not this was an operation that could responsibly be offered to people with Crohn's disease of the large intestine that was wholly isolated to the large bowel. So no small bowel disease, no anal-perineal disease. And so kind of championing this was Vic Fazio in Cleveland. And so what they did was that historically they had a group of individuals that they operate on for ulcerative colitis, and a few days later the pathologist would call and say, hey, you know, now that we have the whole specimen out, we actually believe that this is Crohn's disease. They had another cohort of individuals that did fine, and their initial specimen evaluation said ulcerative colitis, but then years down the road they started to present with inflammation of the ileal pouch, more proximal small bowel, or fistulas, and for all intent and purposes looked like they had Crohn's disease. And so So then they threw into the mix this third cohort were people that walked in with card-carrying Crohn's disease of the large intestine, but no small bowel or anal perineal disease. And in all three cohorts, these individuals underwent a restorative proctocolectomy with pouch anal anastomosis. And what they found was that after an average follow-up of more than or nearly 8 years, that the pouch failure rate overall was about 1 in 3. But if you looked at those people that had card-carrying Crohn's disease that were offered a pouch anal anastomosis, their recurrence rate was 15%. In those where the pathologist called and said, hey, we actually found Crohn's disease in the specimen as opposed to ulcerative colitis, it was the same number. And if they looked at those people that came in with problems, then, guess what? That half of those people lost their pouch at 10 years. So it seemed that whether you knew that they had Crohn's disease before the operation or after the operation, they had the same outcome, which just stands to reason. And when you asked about those people that still had a retained pouch, their median quality of life was rated a 9, which was comparable to what they were seeing in their patients with ulcerative colitis. So how does the IRA compare to the pouch anal anastomosis? And this is 75 patients undergoing an IRA, and now instead of 20 patients, the Cleveland Clinic experience had gone to 32. The group undergoing a IRA were a little bit older than the ones undergoing a pouch anal anastomosis, and their median follow-up was quite a bit longer with the IRA. But what they found was that urgency, incontinence, use of pads, and stool frequency was all comparable and non-significantly different between the two cohorts with a comparable median quality of life. But what I would say is that if you look at it, that everything kind of tends to favor the pouch anal anastomosis over the IRA. And it's just because those people having an IRA still had small bowel disease in their history, they still had anal perineal disease, and there's other things at play, and they're a little different cohort of individuals compared to those that are strictly large bowel disease. So how about this other pouch rectal anastomosis? Well, again, with FEZA, we had reported our results, and of 22 patients undergoing this operation, they had minimal small bowel disease and minimal anal perineal disease, median follow-up of, again, almost 9 years. And we saw disease recurrence in about 2 out of 3 individuals, usually about 1 out of 4 or 1 out of 5 would see it within the iliopouch. 40% in the rectum. The pouch failure rate, however, was very small, only 1 in 10 at that time, and the quality of life, you can see, was quite comparable to what we saw with the pouch rectal anastomosis. So in appropriately counseled and selected individuals, it seems like it's a good offer. And the study went on to kind of compare it to the people undergoing a straight ileorectal anastomosis, and it tended to compare favorably to that straight ileorectal done at the top of the rectum as opposed to this pouch, 10 centimeter pouch done at the mid-rectum. So in summary, patients with Crohn's disease of the large intestine are referred for surgical intervention for a variety of reasons, but failed medical therapy seems like it's the leader there. And proctocolectomy historically and probably in this day and age continues to be the default procedure and the gold standard to which everything gets compared. The alternatives to a permanent ileostomy, though, are sphincter sparing in nature, and they're typically performed in more than one stage, and it's really contingent upon the patient's overall well-being and their distribution of disease and severity of disease. And they selected individuals can be offered these sphincter preserving operations, but only if they understand the associated risks for both recurrence as well as neoplasia, and agree to be compliant with whatever therapy they're looking at or faced with in the future, as well as that need for continued surveillance of that at-risk bowel. So with that, I'll conclude and look forward to the panel. Thanks.